Okay, we're going to go ahead and get started so that we can utilize all our time for our speaker. And so, welcome to the seminar. I'm Marie Harvey, Associate Dean for Research in the College of Public Health and Human Sciences. And I'm delighted that you are participating in this seminar today via Zoom or in person. We do have a couple of people here, so we're doing this hybrid. And Veronica will tell you more about how to participate in the Q&A in the webinar. So Veronica Irvin, who's an associate professor in health promotion and health behavior, has graciously agreed to moderate this session and to introduce our speaker today. So let's get started, and let me hand it over to Veronica. Thank you.
All right, good afternoon. Thank you, Dr. Harvey. Thank you. So today we're hosting this again hybrid. It's a webinar on Zoom. I'm sure most of you are familiar with that, but if you have a question, we're going to take questions at the end and we'll have you post that in the Q&A. I'm very excited to meet and introduce Dr. Jessee Dietch to you all. She is here in the she's an assistant professor here in the College of Psychological Sciences, and she's been here now for about a year. Prior to coming to OSU, she completed a postdoc at Stanford, and she did her formal training at the University of North Texas in clinical health psychology. Her research has been funded both by federal grants as well as foundational funding and focuses on sleep. She is a clinical health psychologist and is certified and trained in behavioral sleep. Thank you. I want to make sure. And I'm excited today to have her here to present to our public health and our other faculty and students. She does teach an undergrad research method, so if you're looking for classes to add on, please consider some of her courses in psychology. But today she's going to be presenting on her research on the development and outcomes of an online provider training for cognitive behavioral therapy to help patients with insomnia. Again, we're going to hold questions to the end, but I'd like to have Dr. Dietch start so that we can hear the most of her presentation. Take it away.
All right, getting set up. Thank you so much for having me here. I'm so excited to talk to you all about this project. This is something I've been working on since my time in graduate school and will be working on, I think, for many years in the future. So a project very close to my heart. Just before we get too far, wanted to just offer my disclosures related to this project. I think it's relevant. This is a little delayed. Okay, some potential conflicts of interest related to this project in specific. This project was funded by the Department of Defense and our kind of path to commercialization. It is now registered as an LLC, which theoretically will yield us amazing profits at some unknown time in the future. Not currently benefiting financially whatsoever. The potential is there someday, we hope. My research is supported by a variety of foundations and agencies, and I'm also a consultant. Those things are unrelated to this project, though. So a little bit about me. Thank you for that lovely introduction. But I just wanted to contextualize it so folks know who I am over in the School of Psychological Science. So I am assistant professor, a licensed clinical psychologist, board certified in behavioral medicine. And over in psychology, I direct the sleep health assessment intervention and dissemination lab, or SHAID lab for short. So what does that stand for? It's kind of a mouthful. If we start kind of at the bottom with assessment, this is talking about defining, validating sleep health assessment tools, really making sure that we're accurately assessing sleep. Measurement is kind of the foundation of doing precise science, and so this is something that's really important to me. Assuming that we are measuring things really well, for me, the next step is intervention, specifically psychological interventions for sleep disorders. So identifying intervention targets, developing and testing interventions, and then the next piece of that is actually disseminating those interventions. So we have a wonderful intervention. How do we get it out into the world, make sure the people who need it are actually receiving it? So I kind of vary along these three lines of research. They intersect a lot. Today, we're going to be spending the most time kind of at that highest level, at the dissemination level. So the objectives of my talk today going to be kind of a good news, bad news situation. So the bad news, I'm going to talk about the consequences, the prevalence of insomnia disorder, which is, can be a really debilitating chronic condition. The good news is I'm going to talk a little bit about our solutions, our interventions that have been developed for treating insomnia. Back to some bad news. It's hard to find this treatment for insomnia. And even though it's great, we're kind of stuck at the dissemination point. And then wrapping up with some good news, talking about our project and our solution to this issue. So first, let's start with insomnia. I know I'm not talking to primarily clinicians here, so I like to make sure we're all on the same page about what am I talking about when I say insomnia, specifically insomnia disorder. Our diagnostic and statistical manual defines it by a number of criteria. The kind of hallmark feature is the difficulties falling or staying asleep. Generally, that's kind of a rule of thumb of about 30 minutes, either with falling asleep or staying asleep or some sort of combination. And that has to occur at least 3 times a week. So, occasional insomnia here or there, very, very common. We've probably all experienced it, but having it kind of on this consistent basis 3 times a week or more is going to help get you to that level of being diagnosable for the disorder. And to be considered a chronic disorder has to be occurring for at least 3 months. And there also has to be some sort of associated dysfunction during the daytime. So either difficulty concentrating, mood problems, sleepiness, fatigue during the day, somehow also manifesting as a problem. And what is the prevalence of insomnia? About 35 to 50% have sub-threshold, subclinical symptoms of insomnia. So maybe meeting the nighttime symptoms, but not qualifying in the daytime or not having it at the frequency that would qualify one for the disorder, which is hugely prevalent. And then 5 to 15% of the general population is going to meet criteria for the disorder, which I think is a pretty staggering figure. One of the most common psychological problems that we see, and it also varies. Tends to be more common in certain age groups, in certain race ethnicity groups, and also varying by things like caregiving status, work schedule, a number of kind of different factors that can modify the prevalence. So this is something probably a soapbox that I would get on a lot, but there's a sort of a misconception that insomnia is just a secondary issue. It's something caused by other disorders and probably doesn't really warrant study on its own. And I think us sleep researchers have been pretty aware that this is not the case, but it's sort of just getting into the mainstream, this idea that insomnia is in fact not a secondary condition, but it really deserves and merits study on its own. So, yeah.
Microphone's cutting in and out. I'm wondering if maybe the placement is passing up.
Let's try that again. No problem. All right, tell me if this is better going forward.
Those in the Zoom, let us know if this gets any better. Thank you.
Okay, great. So one of the points of kind of evidence saying that insomnia is not just a secondary disorder, it's actually a problem on its own, is this idea that insomnia often precedes or can come before a comorbid issue. So you may start to have symptoms of insomnia, and that could precede a depressive episode or a medical problem. And so this kind of gives us some sense that insomnia can kind of develop on its own outside of the context of comorbid disorders. But even when it does develop kind of following on after some other medical or psychological problem, it often develops a life of its own and kind of becomes independent and sort of takes on its own independent disease status, even if the initial cause was perhaps some other comorbid disorder. And another sign pointing to the fact that insomnia kind of is its own piece standing alone is that often if we treat the comorbid disorder, so we treat depressive disorder, insomnia is one of the symptoms or really truly one of the disorders that kind of remains even after the depression remits, post-traumatic stress disorder remits. So it really has taken on a life of its own at this point. And the kind of common thinking now is that insomnia, most often co-occurs with other disorders, and it may kind of be reciprocally exacerbating. The disorders may be exacerbating one another. So increases in depressive symptoms leading to increases in insomnia symptoms and vice versa. So all that to say, you know, our diagnostic classification systems are really considering insomnia to be comorbid rather than something that's a secondary disorder. So that's kind of my impassioned plea to say insomnia is important and we should give it attention. And one of the other reasons that we should give insomnia attention is that it's associated with a score of occupational, social, health, psychological outcomes. And insomnia is unlikely to remit on its own. About 50% of those with chronic insomnia at the 1-year mark do not experience remission. So insomnia is unlikely to go away without having some sort of targeted treatment. All right, on to some good news after that doom and gloom. So we do have an excellent treatment for insomnia called cognitive behavioral therapy for insomnia. So I'm going to tell you about some of the merits of this treatment now. And CBTI, as I'm going to refer to it going forward, a couple of things you should know about it, just kind of before I describe the therapy in a little more detail. This is a brief psychotherapeutic approach, especially compared to some of our treatments for things like depression and anxiety and PTSD. Generally, most clinical trials are testing 4 to 6 week sessions. So presumably 4 to 6 weeks, and the patient can be experiencing significant relief from their insomnia symptoms. CBTI is evidence-based. It's kind of a hallmark of it. It has a very, very strong evidence base supported by numerous meta-analyses. And I'll talk a little bit more about the evidence base in a few slides going forward. CBTI is multi-component, meaning it's not just one single element, but it's a number of elements that can kind of be configured, added in to treatment to target the specific presenting problems that the patient may be having. It can be kind of a flexible treatment in that way and address sort of different facets of insomnia. And I'll be going over those components so you can get a flavor of kind of what the treatment actually can look like. It's a non-pharmacological treatment. I'm a psychologist. That's kind of our general domain. And CBTI can be either, it's been studied in both therapist-delivered and self-delivered formats. So there's kind of this growing popularity of digital CBTI, which is like a self-guided kind of app-based approach. That is an excellent path to dissemination and kind of a different approach than we've taken. And I'll say that the kind of most effective approach to CBTI is the therapist-delivered approach, specifically individual one-on-one therapy, but digital CBTI and self-guided is definitely an option for some folks that can be helpful.
So, if we continue that, I'm wondering if I should hold this.
All right, let's try that. No, it's fine.
Is that okay?
Yeah.
We'll see if that's better.
We'll see.
Yeah.
Okay. Sorry about that. Okay, so let's talk about what some of these components actually look like. So one of the components that has the strongest evidence base is called stimulus control. And the idea of this component is essentially trying to reshape the patient's relationship between the bed and insomnia, and reshaping that into kind of a less fraught relationship. So improving that association with the bed and bedroom. People with insomnia describe kind of the bedroom becoming sort of a war zone where every night they kind of dread entering it. They know they're going to have this experience of insomnia. So changing that association is kind of the goal of stimulus control. Sleep restriction, it sounds scary, sounds kind of like the opposite of what you might want to achieve with insomnia, but in reality, people with insomnia tend to spend a lot of extra time in bed awake, and so it's kind of cutting out that time in bed awake. So it's really time in bed restriction. We're not really reducing their sleep, we're just trying to consolidate it and make it a higher quality. We also have cognitive therapy, which you may be familiar with, essentially addressing some unhelpful beliefs about sleep, reducing worries or fears about sleep, and reducing cognitive arousal that's occurring at night that's kind of interfering with the ability to relax and fall asleep. Psychoeducation can, be helpful to some extent, educating people about what may or may not be helpful for their sleep so they can make better informed choices that are going to actually support their sleep health. And then relaxation. People with insomnia tend to have a lot of somatic tension or cognitive arousal, so other strategies for kind of reducing some of that arousal. And then there are other components that you may have heard of. Sleep hygiene is a popular one that gets tossed around as being a treatment for insomnia. It's not on its own. It's a very small piece of our evidence-based treatment. And then mindfulness has a role potentially in some treatment courses, other things like biofeedback. So these are other pieces that you could see added into a course of CBTI. All right, so talking a little bit more about that evidence base, I think, in psychology, our effect sizes for our treatments, we tend to be impressed by things that are kind of around a 1 effect size. That's pretty good for us. So CBTI is one of our most effective treatments. The Insomnia Severity Index is probably our most common outcome measure. In insomnia trials, it's just a symptom measure. And you can see that that's kind of where we're seeing our biggest effect size, some kind of smaller effect size for some of the other pieces of insomnia. So specifically things like sleep onset latency, how long it takes you to fall asleep, or wake after sleep onset, how long you're awake during the night, during your sleep period. Those kind of fall in the medium range. And then things like actually the number of awakenings and actually the total sleep time doesn't actually move that much, which I think can be surprising to folks. We think, oh, insomnia, that means you need more sleep. But in reality, folks with insomnia actually need to improve their symptoms of insomnia, which does not include shortened sleep duration necessarily. So we're not looking for a change in total sleep time. We're actually looking for a change in some of these other metrics of sleep and just sort of the overall feeling about the quality of one's sleep. And for those of you who are fans of medications, I will say they certainly serve a place, but in insomnia, I think medications kind of take a secondary role based on the data that we have, which is that our CBTI tends to be more effective for most of the things that we care about in insomnia. So again, the time it takes you to fall asleep, CBTI is beating out pharmacotherapy. Same thing for wake after sleep onset. Same thing for sleep efficiency, the percent of time that you're actually able to fill with sleep during the night. And then we see the reverse here for total sleep time. So again, that idea that medications maybe are helpful for increasing the amount of sleep, but folks report that they don't feel that the quality of sleep, or really specifically their daytime functioning, has improved too much when they're taking those medications for sleep. So patients tend to express a preference for non-pharmacotherapy interventions. And then in the metrics about sleep that we care about with insomnia, we tend to see that CBTI is really outperforming pharmacotherapy. All right, so some of the, I guess this is my last slide, kind of selling you about how well CBTI works, which is some of our outcome evidence in terms of the treatment. So, in terms of what the benefits look like, studies have found between 60 to 80% of patients are benefiting in some way, some measurable way from CBTI, which is a pretty good treatment response. And about 40% of patients achieve what we would consider to be clinical remission of insomnia, which again, in psychological terms, I think that's a pretty good remission rate for us. In terms of that symptom cluster of falling or staying asleep, we're seeing reductions in the neighborhood of 50 to 60% of that time reduced. So if it was taking you an hour to fall asleep, now 30 minutes or less perhaps. So again, patients report that feels like a pretty substantial change for them. Now, we also have patients with comorbid disorders who come in with initially having more severe sleep disturbances, unsurprisingly, and they tend to leave therapy still having more residual sleep disturbances, so less likely perhaps to achieve remission, but we do see that the magnitude of the treatment response is similar between people with comorbid disorders and without. So they may be starting higher and ending higher, but the magnitude of response tends to be about the same. So it does work for folks with comorbid disorders, just maybe a more complicated picture. They may need more time in session, that kind of thing. All right, and all of these organizations have endorsed CBTI as the frontline treatment for insomnia, releasing clinical practice guidelines. So it's pretty well recognized by a lot of organizations, including the American College of Physicians, which is pretty impressive for a group of physicians to recommend a psychological treatment as the frontline treatment. I think that kind of speaks for itself in terms of the impact of this intervention. All right, we're back to some bad news, which is we have a great treatment. How do people get it? And the answer is that we don't have enough people providing CBTI at this time. So this is a figure from a study from 2016 that looked at behavioral sleep medicine providers around the world. You can see the majority of the world has 0 behavioral sleep medicine providers. A denser concentration here in the US, Canada, Australia, but really lacking across most of the world. And specifically, we zoom in to the US, we can see that even within the US, there's a huger concentration, kind of California, Texas, on the East Coast. There were some states, in 2016 that had 0 providers within the United States, which if you're familiar with psychological practice, we can't practice across state lines unless we're licensed in those states. So potentially people in certain states would have 0 access to this type of treatment. And in Oregon, we look at, I think, 1 to 9 providers. This was in 2016. I'm one more that's been added, but I think we're still in that 1 to 9 category, 6 years later. So it's not very prevalent. And why is that we don't have providers who know how to do this amazing treatment? One reason I think that is a bottleneck is that clinical psychologists, who would probably be the kind of main folks that we would think might be trained in this treatment, are just not really trained in sleep in their clinical training programs. I had an exception. I went to school with a goal of getting trained in this and was able to find one of the very, very few programs that actually offered training in this, but the majority of programs have almost no training in sleep, which you can see here. This is a study of 200 providers nationwide. And, they felt most of them felt kind of moderately prepared, a little prepared, or not at all prepared to treat a sleep disorder. And it gets worse. If we actually ask them kind of a quiz type question. So what is the first line treatment approach for an adult patient presenting with insomnia disorder, which you all know the answer to now, right? Not even clinical psychologists, but you know the answer. But unfortunately, these clinical psychologists do not know the answer. The majority of them said sleep hygiene instructions, which is not an effective standalone intervention for insomnia. Only 16% of them said cognitive behavioral therapy for insomnia. So they may even think that they're more prepared than they really are to treat this disorder. So I made a GIF to remind you that sleep hygiene is not CBT for insomnia. CBT for insomnia is the frontline treatment. So this is a really kind of busy slide. I don't expect you to read this all, but this is from a review kind of outlining what are the barriers, why are we not getting CBTI out there? And the one that I've talked about today and the one I'm going to keep talking about is clinician barriers. So we also have barriers at the systemic level, kind of the barriers that are preventing people from getting psychological treatments in general, access to payers, access to providers in general. We also have patient barriers. Patients are not familiar with CBTI. There are, of course, barriers associated with completing any psychological treatment. And so we're focusing today on just, one piece of this, one level, the clinicians, that we don't have enough clinicians trained to deliver this. So this is our contribution to the puzzle. All right. Now we're going to only talk about good news from here on out, which is CBTI Web, which is our approach to addressing these clinician barriers. to CBTI. And so the main objectives of this project, like I said, it was funded by the DoD as a 5-year project. And we were hoping to develop and test a web-based provider training for CBTI. We were hoping to iteratively refine that training so that we could, not just release one version, but really try to improve it and make it meet clinicians' needs as good as well as possible. And then we wanted to compare that effectiveness of that training to kind of a typical training course, so an in-person training course for licensed providers. So I'm going to go through each of those steps. We started in September 2017 with our development and then our 3 phases of testing of this project. So first I'm going to talk about the development phase and what that actually looked like to develop a web-based provider training. So, one of our thoughts was that clinicians are just not able to access training. They don't get it in their training programs. They may not be willing to travel to an in-person training to be delivered. So something developed on the web that could be accessed from anywhere all over the world would be one solution to kind of addressing this issue. So our development process, we had a kind of a storyboarding and content development piece where we just sort of sketched out what we thought a training would look like online and kind of how we wanted this to look and flow. And this was an iterative process as the entire project was, I will say, but going over it many times. We then did some video shoots to actually display the techniques. So what does it look like for a provider to actually deliver these techniques, which is one way that people say that they learn to do therapy the best. And so going back to my background a little bit, something I didn't mention, I have a degree in film production. So that was kind of a happy accident. So I ended up facilitating these in graduate school. And we set up these scenes and recorded them with real providers and who were experts in the field and actors as our patients. Then we also shot some videos of subject matter experts just kind of displaying the information. We figured it was better to kind of use a video delivery of information rather than just reading a lot of text. And so kind of try to keep things more interactive, more engaging. And then finally, we actually had an in-person meeting where we kind of tested out this format. We really wanted to make it look and feel as similar to an actual in-person workshop as we could. So we had our subject matter experts give an in-person workshop and then come into the studio and kind of give the same information directly to the camera, serve as our experts on camera. So we did learn some lessons throughout this process. A lot of lessons. One of them is that acting is hard and that people who are subject matter experts are not necessarily also incredible actors. Those skill sets, in fact, do not overlap as much as you might expect. So, I think I'll talk a little bit about future directions, but I think going forward, if anyone's thinking about doing something similar, it's tempting to want to do it yourself, but really hiring folks who are professionals to deliver the content ends up working out a lot better. But our subject matter experts were incredible and we got there. It just took us a lot of iterations. Practicing a lot. There's a big difference between kind of giving a talk off the cuff and actually being able to deliver it on video in a way that's interesting and makes sense. So there's a bigger gulf there than you would think. So practicing and then using scripts as well, instead of trying to go off the cuff, actually using a teleprompter, writing out scripts ahead of time and really kind of planning things out. I won't spend too much time on this, but these are the modules. We ended up developing 10 modules for our training, and they kind of build off of one another. You have to start with the basics of sleep, talking about sleep assessment, and then kind of going through each of the components from there. Once you kind of have completed one and passed a post test, then it will unlock the next module for you. And I'll show you actually just what the actual website looks like. And I think this is a video that will sort of walk through it. So this is our website, and you can see They're kind of the modules that are here. Here they've all been kind of unlocked, but you can kind of progress through each of them, and going to one of the modules, you can actually dive in and see what each of these sort of videos looks like. I think they'll click through one, yeah. So this is one, our videos of our experts. I'll move on from there. If you want to read more about our development process, we have a paper that we published in Military Medicine last year describing the development process and some of our kind of early metrics iterating on that. All right, next I'm going to go through the 3 phases of testing. I'm not going to get too far into the minutia of this, but I just kind of wanted to describe the overall process of what that's going to look like. So we started with an alpha testing phase that only lasted a couple of months. Then we proceeded to beta testing, which again only took us a couple of months. And then we actually ran this comparison study where we compared people who had been trained on our website to folks who were trained kind of in a more traditional sense. And this is what our methods look like, and they're actually quite similar across all 3 phases. So I just sort of lumped it in together here. Our participants were people who were CBTI naive, so had not been trained in CBTI, which, as you might expect, was pretty easy to locate that group, most trainees, and also licensed folks. And then we had an alpha testing phase, beta testing phase with a little bit larger group, and then our comparison study group as well. And our measures, some of the things that we looked at across all 3 of these phases, we had a knowledge check, so pre and post module tests, and then a total overall kind of pre and post knowledge check, just assessing knowledge gains to make sure they're actually internalizing the content. We looked at some computer and web usability questionnaires. So these were checking things like how well can you actually navigate the website and how well is it actually teaching you the content. So more kind of about the process of using this site. We also assessed kind of the satisfaction with using it. So looking at those last 3, the system usability, website content, you can see in our alpha phase, we actually started, I think, pretty high in the 70% for system usability and 90% for website usability and content. So I think when we actually started with the alpha phase, we were in quite a good place. Our content was actually really solid, and that's because of all that iteration we did during the development process. So you can see we got a little bit of a gain. These are statistically significant gains from alpha to beta, and then not much of a change to the comparison study. We only made a couple of tweaks to our videos and to our content between the beta and the comparison study. So we actually, by the time we got to here, we were actually pretty far along in development, and happy to see that people were pretty satisfied with it, even at the outset. And our comparison study, so again, comparing the online training to an actual in-person training, you can see that our knowledge acquisition before doing the training and after doing the training, that was the same between both groups. So they were equivalent. And I will say we were not powered for a non-inferiority design. This is kind of more of a pilot level, but it seemed like this was a pretty clear comparison. The feedback from participants was kind of similar across both conditions as well. And then, very exciting, we actually launched the project to the public. So not just developing it, but actually getting it out there. And we launched on April 1st of 2020, which may be kind of a date that maybe stands out to you a little bit. Our launch, we had originally planned to go to conferences and organizations and present in person and kind of announce this, but we ended up having to scale everything back and present a lot of virtual conferences, listservs, announcements to professional societies, which I actually think worked out in our favor. This, obviously coincided with the start of the pandemic. Everyone was kind of just going to working from home and needed things to do before they got their infrastructure for working from home set up. So we had a huge boom of people who took the training like right when it launched. Maybe got a little boost from the pandemic. And then a year later, we looked at kind of that data, who actually signed up for this in the first year. So we had over 5,000 providers who registered for the training in that first year, and just over 1,300 who completed the training, passed the post-test, and actually received continuing education credit. So took the website all the way through to the end. So this is a huge amount, kind of by comparison. Another training initiative that sought to train providers in the VA to deliver this treatment achieved, I think, about half of this number in about 4 years of training. So, we really reached a lot of people in that first year. And zooming in a little bit on the first 3 months after our launch, we registered 2,500 people in the first 3 months. So like I said, we got a huge boost right there at the beginning, and just over 500 ended up kind of going all the way through the training and completing the post-test. So a good attrition, but also a nice number that's kind of following through and finishing up. And who are these people who actually ended up taking the training? So this is just the folks who actually completed the training within that first 3 months. So looking at 600 folks, and about half of them were at the master's level clinicians. So this is potentially trainees, people who are in PhD training programs, or people with a terminal master's who are, can be licensed to provide mental health treatment. A good chunk of them were also doctorates, about 40%, and then a small minority were people with bachelors or lower. So this could be folks who were just really interested in insomnia, or lay people who found the website. It was not restricted that way. And then what are the disciplines of people who completed? About 60% were in psychology. So what we expected, most of our contacts and resources are in the world of psychology, and that's kind of our target audience of who would be providing this treatment. We also have folks who are in social work, counseling, and actually a surprising number of people in medicine. So, potentially physicians, PAs, who also could become, competent and deliver this treatment as well. And only 3% kind of falling under other. So that would be disciplines that maybe we wouldn't anticipate would be taking this training. Diving in a little bit more, who are these people? And we had pretty good representation around the United States, and actually just over 5% outside of the US as well. A good deal were Southern. We did concentrate a lot of our advertisement in Texas and South Carolina, which is where our groups were located at the time. So probably why we're seeing some over-representation there. But, we kind of captured folks from all over the US and outside the US as well. And then what settings are they actually working in? Folks in private practice represented a good chunk there, so about 20%, which is, that's kind of nice. Those are people who are out there providing interventions and looking to expand their competency to include CBTI. So that's probably people who are going to really be able to access patients with insomnia pretty readily. We also had folks within the VA. This is a military base, academic medical centers, college campuses, just kind of general psychology settings, hospital settings, and then other settings. I think a lot there. I wish we'd had a free text and could kind of see where those other folks were coming from. All right. Now, I will talk about our knowledge gains in brief. This is each of our different assessments. You can see the pretest in the lighter bar, a little hard to see, and our post-test in the darker bar. They go up for each of them, which is great news. This is our actual real-world implementation data. And you can see the kind of biggest gains are actually in the kind of specific sleep modules. So some of these things like relaxation, cognitive restructuring, problem solving, these are things that clinicians are probably already familiar with. They're just kind of contextualized to be more about sleep. But where we're seeing the biggest gains is in things that are really sleep specific. So again, reinforcing that idea that maybe these clinicians have not received a lot of exposure or training to specifically sleep related content. Where are we now? This is a little out of date. I haven't pulled the latest numbers in a little while, but as of July 9th, 2021, we moved to a payment model for CEs. So until July of last year, the training was completely free. You could get continuing education credits for free. Now we've moved to a payment model where if you need continuing education credits, it costs $65, but the actual training itself is completely free still. So if someone wanted to take the training, go all the way through, get the certificate of completion, still completely free, and we intend to keep it that way forever. And we also have a discount for military and VA providers, a stipulation of the DoD funding. And we intend to make changes and kind of updates to the website semi-annually, which is why we ended up starting the LLC and wanting to kind of have our collect the funds for CEs so we can sustain the website long term. You know, a lot of projects like this will be grant funded initially, and then there's no sustainability plan. So the website kind of falls into disrepair, the information gets outdated, starts to look like it was shot 20 years ago. So we really wanted to avoid that and have some way that the website could kind of sustain itself, and you know, just give us enough money to work with that we could keep updating it in the long term. So that's the plan. We're kind of in that phase. The grant actually ended on Monday, so we are fully on the support of people using the website at this point. And if you want to read more about, you know, those kind of training outcomes, you can read our paper was actually just published a couple of days ago, EPUB'd, so you can check that out. That's looking at that first year, engagement rates, knowledge acquisition, etc. All right, I think I'm going to skip through the cost analyses kind of quickly. This is a project that I'm writing right now, actually, taking the lead on, something I'm not an expert in, so it's taking me a while to kind of wrap my head around cost analyses. But you know, we wanted to compare the in-person workshop cost to the actual CBTI Web platform and see, you know, how much cost savings are we looking at in terms of being able to access this online, not take time off of work, not have to travel. And our sort of preliminary findings here is that initially, of course, you know, this was a $2 million grant from the DoD, so that was a large chunk of money up front. But over time, if we can kind of keep sustaining it and providing trainers or providing providers with training kind of at a rate we've been going, then we're going to see that that is really over time balancing out. And in fact, you know, if we look at the 4-month mark, this is where they kind of equal each other. And then beyond that, at the 1-year mark, we reached where this is a lot cheaper per provider to train folks online. And eventually we kind of think at the like 5-year time horizon, it will hit a much lower cost per provider. Finally, I'm going to talk about the future directions of this work and what we're working on right now. So at the 1-year follow-up, we actually asked more questions of our providers to see, are they actually implementing this in their practice? How well trained do they feel? Are they feeling confident in their ability to deliver this treatment? And this is actually one of our graduate students, not here at OSU, but one of the other investigators' graduate students using this as her dissertation work. We also received a similar grant from the DoD to do this again for nightmare training. So teaching providers how to treat nightmares. And so really excited. We just launched this project a couple months ago. And so we're doing it all over again with all of those lessons learned, doing it so much better this time. And then finally, we want to increase the consultation pipeline as well. So we know that just getting a web-based training, 6.5 hours of training is probably not enough to create a competent provider. It's kind of the minimal competency. So we would like to make it easier for providers to kind of get ongoing consultation to ensure that their knowledge gains remain. They can actually apply the information, ask questions going forward. And this is our core team. Took a lot of folks to get this off the ground. And if you have any questions, take those now.
So I'll try and talk. I'll talk what we're going to try and talk about. Thank you for presenting. All right, Dr. Dietch, I'll leave you the microphone.
So we'll start. If you have questions, please post those in the Q&A. But we're going to start off with a couple, hopefully, questions for our audience would be, we've learned now that sleep hygiene is not CBTI. Can you just briefly say what sleep hygiene is and what it isn't?
Yes, absolutely. So sleep hygiene is it's a list of recommendations. You've probably seen something like it before, like how to get good sleep. So this is things like turn off your electronics 2 hours before bed. Don't exercise too close to bed. Don't drink caffeine. Don't drink alcohol too close to bedtime. Make sure that your bedroom is quiet and dark. Things like that. So what we see is that people with insomnia come in and they tend to have done all of those things and it doesn't seem to have fixed their insomnia. In fact, they tend to have great sleep hygiene. You know, they're sleeping in a beautiful cave with no electronics, but still they're not sleeping. So
Thank you. And what would be some differences between an in-person or traditional format and your online? And how is it more effective or do you see long-term effects?
yeah, I mean, I think we actually aimed to make the in-person training and the online training really line up. So we wanted, you know, I think we've all sat through those sort of online trainings that are like a huge snooze. You know, you're just trying to click through and get through it as quickly as possible. We did not want to have that. So we really wanted to have our engaging speakers. And so we tried to kind of mimic that in-person format as much as possible. And I think the big difference is that our web-based training is more accessible, right? You don't have to pay, you don't have to travel to get this training. It's on demand. You can, you know, fit it into your spare time or, you know, on your lunch break, you can watch a couple videos and learn, and then always be referring back to the resources on the website.
Great, thank you. So please, if there's any questions from the audience, raise your hand, and in chat, it'll let me know if there's any Q&A questions.
Nothing here.
I'm gonna ask
a question.
Yeah, CJ.
One thing I wondered is, like, generally, do people end up doing CBTI plus medicine, or do they stop the medicine while they do CBTI, or how does that work?
Yeah. Yeah, that's a great question. So the question was whether people tend to do both CBTI and medication at the same time, or if they are able to kind of reduce medications while over the course of CBTI. I would say, you know, it really depends on the population. A lot of the times, you know, we'll get folks into our offices who are on medications. They're still in our office because the medication isn't doing what they want it to do. Maybe they want help coming off of the medication. So in that case, you know, I will generally help people to meet their medication-based goals while we're doing CBTI. So maybe coming down off of the medication, if that's something that they're ready for, or maybe getting their sleep on track and then coming off the medication. But generally, I don't usually encourage people to start a medication or to seek that from their physician, unless, you know, we've gone through a lot of CBTI and a lot of options and tried to get their sleep, you know, in a better place without medication. Those medications are really developed for kind of short-term use. They're not really meant for long-term use. And so they don't really solve the insomnia problem. Once you come off of them, the insomnia tends to come back.
In the audience, do you have a question? Yes, Javier.
Yeah, well, great presentation. Thank you for very interesting presentation, very important. So one thing I want to say is that you are not alone. The mainstream medicine and public health continue to ignore sleep for the most part. Cardiologists, I mean, the American Heart Association continues to only recently has included a mention of sleep apnea as something you need to pay attention to when you want to control hypertension, despite decades of research showing, including clinical trials, showing that for obese patients with sleep apnea, controlling the sleep apnea is critical to control their hypertension. But that's just for some reason, this continues to be ignored by cardiologists and practitioners all the time. And in part is that the same as in clinical psychology, training is not or has been not until recently part of the basic training of physicians and healthcare providers in general, nurses, etc. So, which leads me to my question: when do you think that's going to change in clinical psychology? And clinical psychologists will be trained in this critical component of health.
Yeah, absolutely. So
repeat the question.
Yeah, the question was, when will this change for clinical psychology? When will we actually see people being trained in sleep in these clinical psych programs? I mean, if it were up to me, it would be today. We're actually, I don't know if all of you are familiar, we're actually starting a clinical psychology PhD in the College of Liberal Arts within our School of Psych Science. So, my goal is to have sleep be a really large part of that training. And so that will be one more program added in, but kind of on the national level, I'm not sure what it's going to take. Honestly, I think advocacy from our professional organizations is something to kind of push on. I think we know that this is a problem, and that paper that I talked about, talking about the lack of training in psych programs, just came out last year. So drawing attention to that lack is still fairly new, but I'm hoping that kind of the awareness, even if it's not being trained in clinical psych programs, now at least people have the option to seek out training, with our provider training platform, and to kind of be independently trained in that area if it's something they see. I think providers notice that it comes up in their practice a lot. Patients mention sleep, they want help with sleep. And so, that might drive providers hopefully to seek out the training.
That was kind of my follow-up question was, what could patients do? And is there a big push from patients to have more of this type of care?
Yeah, so the question is, what can patients do? And are patients recognizing the need for this? I think that it's starting, more slowly, but I think patients are starting to recognize it. I mean, one thing that's happened recently is that an app for CBTI was approved by the FDA to be prescribed. So ironically, it can be prescribed by physicians, not by psychologists. But that is one avenue. So again, the self-help avenue, that app is called Somrist. And so that's one avenue that patients can, seek out this like self-help version of CBTI. There's also provider directories online. Patients can look for, listings of who's trained in this. We're hoping, a kind of a next piece on CBTI Web, and I didn't mention this, but we're hoping to make a formal provider status associated with the training, completing the training, and consultation along with that to kind of demonstrate competency. And then, that'll be like any other kind of certification where you can demonstrate your competency. Hopefully patients can seek out people with that level of certification. So that's on the to-do list.
Thank you. Great. You want to, but maybe Javier, maybe we'll walk the microphone back
Yes.
No, it's okay.
Just talk loud. Okay.
Yeah, that's another question, quick question. So the other big sleep deprivation issue, as you know, is aside from insomnia, is voluntary sleep deprivation due to our addiction to social media and screens, etc. How much of this could you think could be translated to or adapted to treat those disorders?
Yeah, that's a great question. So the question is, this other issue in sleep, probably the most prevalent problem other than insomnia, is voluntary or insufficient sleep, just kind of in favor of social or occupational activities instead. And how much can what we've done here be translated to that? I mean, I do think they're fundamentally really different problems, and I think that the insufficient sleep problem tends to be a little bit easier for the media to kind of grab onto and advertise, so it gets more face time. Things like popular press books, Matthew Walker's book Why We Sleep, really popular book, kind of doom and gloom and trying to sell you on why you need to sleep more, but doesn't do much for people with insomnia. They know they want to, they're not able to. So I think that it's a fundamentally different problem, and that's I would kind of link it to some of our larger societal issues of our sort of productivity culture and our lack of restfulness. And I think that's a different issue kind of on the societal level. I think sleep is getting more attention. It's becoming more in vogue to think about sleep as part of like the overall wellness package. So I think that is probably good for that issue, but probably not doing much in the insomnia space. Great.
I have one follow-up question, or similar. Your funding source, maybe it's different. Your funding source is the Department of Defense, and that may be atypical for some of our health researchers. What was your experience? What does the DoD fund, and is it really, a lot of it's just plain military? And if you could expand on that.
Yes, yeah. So the question was about the DoD funding and and what that looks like. I think it's an interesting place to get funding. It's certainly a different approach than the NIH, but I think a lot of our health topics are actually quite appealing to the DoD. You just have to think about how you can sell it as being something that impacts, soldier readiness and combat readiness, which is maybe language that we're not that familiar with or used to wanting to talk about. Sometimes it feels a little antithetical to my own beliefs, training soldiers to sleep better so they can be better warriors. But you can see kind of, if you can get past that piece, I think you can see the good that we've done here. This is a publicly available resource that we created. Now, because of the military kind of flavor to the funding and the research question that we asked, we do have kind of separate military specific modules and kind of additional content for military providers that civilian providers can just skip. So, we made it flexible so it can kind of serve both. And really we wanted it to be a resource for everyone, just kind of framing it in this way that it's available for.
Great. It's great to hear about that.
Yeah, absolutely.
All right, we'll have time for one last question. Any question from the audience or online? All right, CJ, will you have the last question?
I was just curious because with its DoD and veterans tending to have sleep, it can be a problem. So is it hard? Do they have to use their own providers? Like, do you have any issues with insurance, like, being accepted across for access?
Yeah. The question is about VA and about active duty patients and kind of insurance reimbursement. I mean, that is a whole topic that I could get into. Reimbursement for psychological services is just abysmal. In general, CBTI is no exception. But I think, the VA is actually a great place to get care for sleep. The VA, the rollout that I mentioned previously, the VA had a big rollout a couple of years ago. My postdoc mentor actually kind of led the charge on that. And that is, seeking to train providers across the entire VA to treat insomnia. They've done a similar rollout treating nightmares. And so I think the VA is actually probably better than average place to get care. It's our active duty military that have a hard time getting care because just like any psychological problem, it's hard for active duty to get treatment for that. I do think telehealth kind of makes that a little flexible, more easy to obtain that care, but ultimately I think that they're going to face the same challenges that civilians face as well. I think most psychologists are kind of moving to a private pay model just because of the difficulties with insurance reimbursement. So I think that's something we're seeing.
All right. Well, thank you so much, Dr. Dietch, for joining us today.